Okay, well, maybe we'll get started as some people filter in here. Hi, everybody. I'm Tom J. Ram. I'm a urologist. I'm a urologic oncologist in Nashville. And it's really cool to be here today to talk a little bit about a different kind of angle that a lot of us in urologic oncology are getting involved in and getting interested in, and that's incorporating immunotherapy into our treatment landscape. As we know, immunotherapy has been a very, very powerful tool that has been added to the oncology toolbox for patients with urologic cancers and many other cancers. And so there has been a lot of interest in trying to have urologists understand this therapy better, trying to help them both in the terms of counseling of patients, but also in the treatment of patients, as now several urology groups and entities are delivering these therapies themselves for the appropriate indication. So we'll talk a little bit about incorporating immunotherapies in the treatment landscape, specifically here for patients with pathologically high risk urothelial carcinoma starting in the bladder. We'll talk a little bit about the data that supports this indication for patients with bladder cancer. And then hopefully we'll get some discussion going about how to do this in a structured and in a consistent way so that we can deliver. And if we don't deliver these ourselves, then we could really be on the cutting edge of monitoring these patients and understanding how these therapies are helping patients. Before we start, the indication for Opdivo is as a single agent treatment for adjuvant urothelial carcinoma who are at high risk of recurrence after undergoing radical resection, so either cystectomy or nephroureterectomy. There's going to be a lot of discussion here about safety and adverse events, but basically, in a nutshell, there are some adverse events and precautions that we need to think about. Immune-mediated adverse reactions, some people call them IRAEs, are a whole category of adverse events that we'll talk about. Infusion-related reactions, special populations that need to be monitored, stem cell patients, patients who may be pregnant, and then patients who have multiple myeloma, which has a specific contraindication or interaction with approved therapies. So the objectives here are to understand the need for additional treatments in patients who have urothelial carcinoma and who have pathologic high-risk disease, and we'll define that in a second. We'll provide scientific rationale through the approved study, the study that led to the approval of Opdivo in this space, to show how patients can benefit. And we'll talk a little bit about how urologists help to manage IMARs in patients treated with IO therapies. Again, I think that's a big focus now. We've been quite involved with this, with administering our own checkpoint inhibitors. We've presented several courses at the AUA, and we found that there's a lot of interest from urologists into doing this themselves. And I think that there are some points, some things that you can do to help structure your program in order to do this correctly. And then really a recurring theme of this is going to be the MDT, the multidisciplinary team, and the importance, especially in 2024, of really engaging multiple disciplines, multiple specialists, having people in other realms, medical oncology, radiation oncology, that can provide some support in terms of helping these patients. And then we'll talk about a real case of mine that has benefited from this. So we know bladder cancer, especially in the urological oncology world, is common. Cisplatin-based chemotherapy, followed by radical resection, is a recommended treatment option. And it's not just now in lower tract. As we know, there are new AUA guidelines in upper tract disease that suggest upfront chemotherapy for UTUC is beneficial. The challenge is getting patients timely and appropriate perioperative chemotherapy. And even then, after resection, we know that patients can still have high-risk disease and still go on to recur and progress. So the pathologic T stage of patients after their organ resection is fundamentally very important in understanding their prognosis. Patients who have T3 disease who have not received neoadjuvant chemotherapy, and those who have T2 disease or worse who did receive neoadjuvant chemotherapy, and then I would add node positive patients in either arm of these, are at very high risk of relapse after surgery. And so those patients need to be monitored a little bit differently, and those patients need to be counseled as to the particular options that they may have to reduce that risk of recurrence. Historically, we've given adjuvant cisplatin-based chemotherapy. We know that that may delay recurrence. However, there hasn't been any randomized trials that have suggested a survival benefit. And as we know, administering adjuvant cisplatin is fairly challenging because patients post-cystectomy have a complicated course. They oftentimes have renal insufficiency, and there is a lower rate of retention in giving them adjuvant chemotherapy than there is in potentially some other strategies. So again, cisplatin-based chemotherapy is standard of care, and all patients who can receive this should be encouraged to do this prior to radical cystectomy if they have muscle-invasive bladder cancer. However, what we know is a fairly high percentage of patients, between 30 and 50% of patients, will be unable to receive chemotherapy. And I would probably add another comment that in the community, that number is probably a little bit higher. It's just harder to sell patients necessarily on chemotherapy up front. Why can't patients get chemotherapy? Well, we have the Galsky criteria, which has medical contraindications, specifically renal function, hearing loss, neuropathy, and heart failure. But again, as someone who does a lot of radical cystectomies in the community and is a busy bladder cancer surgeon and doctor, I can tell you that there are quite a few patients who decline or refuse upfront chemotherapy. And that is a particular challenge that we have to deal with in community-based practice. So unlike cisplatin-based regimens, there's no evidence to suggest that carboplatin-based regimens will provide the same survival benefits. So an important thing that we know now, especially in urothelial carcinoma, is cisplatin is much more active against the disease than carboplatin. And if patients have cisplatin ineligible disease, they should not get carboplatin, but they should be considered for upfront radical cystectomy. So really the unmet needs now are that we know that there is a high risk of recurrence even after resection, and that timely perioperative systemic therapy is a challenge, whether it's because they're ineligible on medical comorbidities, they can't get it on the adjuvant side based on their surgical recovery, or a mixture of. We know that it is difficult to get patients, all patients who are eligible, systemic therapy on a timely basis. And as we mentioned, some patients are just not eligible. So when you look at the kind of the roadmap of muscle invasive urothelial carcinoma, I think the first thing that we think about is their disease, appropriate pathologic staging, understanding exactly where they are with imaging and with their pathology. But then we have to start making some very patient-specific decisions on, are they eligible for surgery? And if they're eligible for surgery, can they receive neoadjuvant chemotherapy? And those patients go down that path. If they cannot get neoadjuvant chemotherapy, in my practice, they're offered an upfront radical cystectomy or a clinical trial, as there are several clinical trials now in the cisplatin ineligible space. However, still the standard of care for those patients is to get an upfront radical cystectomy. After we do the cystectomy, we get complete pathologic staging, and then we have a decision. If they are high risk, and we'll define this again, then there is the opportunity to give them adjuvant therapy. And again, we talked about chemotherapy. It's somewhat challenging to give, but now we have immune-based therapy as an option for these patients, which really I think is an important thing to have. It provides patients more access to getting systemic therapy, and we'll show the data supporting it in a second. So, a couple slides about the multidisciplinary team, really fundamentally important. I think regardless of where you are, academic setting, a private setting, bladder cancer is not a disease that you should be tackling by yourself. Being able to have a good multidisciplinary team is really good, is really important in optimizing your outcome. So if patients are eligible for surgery, we always have tumor board discussions with our medical oncologists about their fitness for neoadjuvant chemotherapy. And not all medical oncologists are the same in terms of what they would give patients, number one, but also their criteria for giving them, number two. So it's really important to be able to have those discussions with them to understand kind of the direction that they're going as well. Another really important part of the team is the pathologist. We know this that the especially in our setting in the community, having good central pathologic review, having GU specialists that are reviewing these slides is fundamentally very important. Patients, we know with variant histology respond different to chemotherapy. Some of these patients may even should be considered for early or upfront cystectomy. So having pathologic expertise as part of your multidisciplinary team is very important. And then the decision for adjuvant therapy is always a team-based approach. Patients we review their pathology, we review how the patients recovered, their renal function, what their options are, and then we'll make a decision on whether or not we think that adjuvant therapy is the best. And some patients obviously may benefit from adjuvant chemotherapy, but now we have an option for adjuvant immunotherapy. So let's talk a little bit. Just making sure everyone can see the slides. I got a message that the slides are somewhat challenging to see. Can everyone see the slides? Better now. Okay, good. All right. So let's talk a little bit about Checkmate 274. This is the first and the only phase 3 placebo-controlled trial in the adjuvant setting in patients with urothelial carcinoma. And this was the study that led to the approval. So I think it's important to understand a couple different parts of this trial. Number one is the inclusion criteria, because this is really the meat and potatoes of how to select these patients. But if patients had neoadjuvant chemotherapy and they were stage 2 or above, regardless of their nodal status, or they were node positive, so they could be T1, N1, they were included. That's a high-risk group of patients. The concept is that they have incompletely or inefficiently responded to chemotherapy and are at high risk of progression. If they had not had chemotherapy, they had to be T3 or T4 with node positive disease as well, or node positive disease. And so the surgery was within the last 4 months, and then they had to have disease-free status by imaging 4 weeks prior to randomization. So these patients were stratified, were randomized to either get weekly, monthly Opdivo or a placebo every 2 weeks. Sorry, the Opdivo in this study was every 2 weeks. Double-blind randomized study. They stratified by PD-L1 status and pathologic status, and then they were treated for either up to a year or until they had disease recurrence or unacceptable toxicity. In a couple of important points about the cohort itself, 20% of patients had upper tract disease, and we'll look at that in a second. That was an important stratification factor. 40% of patients expressed PD-L1. If you followed the PD-L1 story in urothelial carcinoma, you know that PD-L1 is not a perfect biomarker for response to immune-based therapies, but there are quite a bit of data suggesting that it's probably the best biomarker we have right now that suggests that patients, the group of patients that may respond best to immunotherapy, and we'll elaborate on that in a little bit. Almost half of the group had neoadjuvant chemotherapy, which again, I think, it's important to understand in the real world. This is kind of where we're at. About 40 to 50% of patients who are have muscle invasive bladder cancer get chemotherapy up front, and we talked about a lot of reasons why that may not happen. And then about half the patients had nodal disease, and if you look at the pathologic breakdown here, you'll see that quite a few patients were T3 node positive or worse, suggesting a fairly advanced group of patients. So this is a the kind of the crux of the data here, and a couple things to really hammer home. Disease-free survival overall, as you can see, at both at 6 months and 12 months, favored the Opdivo group with a hazard ratio of 0.7, so roughly about a 30% advantage. As you can see, this was all comers, so we had both upper tract patients and lower tract patients here. If you broke it down into PD-L1 positive patients, you'll see that that benefit increased quite a bit with the hazard ratio of 0.55. Now, a couple of things here to mention. In the exploratory subgroup, patients with upper tract disease, no improvement in DFS was found. So really the benefit here appeared to be strongly correlative of the lower tract group, of the bladder group, and did not really was not really seen in the upper tract group. And we'll talk a little bit about that more later. Patients who had PD-L1 did not have PD-L1 expression had a DFS hazard ratio of about 0.83. So there was still a response, but clearly it was not as significant as the 0.55 hazard ratio we see in patients who did have PD-L1 expression. So this extended data was presented at the AUA last year, and I think it's really, really important. As you continue to follow these patients out, you see a couple of things that are really important. Again, the two groups are high-risk patients that received Opdivo versus received a placebo. The Opdivo group continued to have a significant median disease-free survival advantage over the placebo group. And then if you take out the upper tract patients, we mentioned about 20% of the group was upper tract, and that group did not seem to have a benefit, you find quite a substantial improvement in this hazard ratio to 0.63. And you can see median DFS almost triples from 8.5 months to 25.5 months. So this is significant in that once the upper tract patients are removed, and the question is, well, why is this? What are the reasons for this? And there's a couple different hypotheses here. I don't think we all know the answers, but we know upper tract disease is different than lower tract disease. From a biomarker standpoint, we'll see more FGFR expression upper tract. We see less PD-L1 expression upper tract. And I think there's more and more data coming out now that suggests that the bladder urothelial cancer is not the same everywhere it occurs in the body. But there's certainly, from a genomic and a transcriptomic profiling standpoint, upper tract disease, I think, is different now, and that may explain some of these differences. So again, importantly here, if you look at in this MIBC specific population, so we've taken out the upper tract patients, and we're looking at patients that have MIBC and are PD-L1 positive. That's this graph on the right. You see a really, really substantial separation of curves and a hazard ratio of 0.44, which is kind of a blockbuster hazard ratio for me, looking at clinical trials all the time to see this kind of number. So to me, that means the group that benefits the most are MIBC patients who are high PD-L1 expressors. You can see that patients who are PD-L1 expressors, all comers on the left, have a significantly better hazard ratio than the group that is all comers without PD-L1 expression. So again, this graph on the right, I think, is really significant. So patients who have high-risk bladder cancer post-cystectomy that have high PD-L1 expression, you have a hazard ratio of 0.44, and you have a median DFS of 53 months compared to 8 months with placebo. So again, really strong data there supporting immunotherapy in that subgroup. So again, this is the non-PD-L1 group in patients who are muscle invasive. And I think, from a 30,000-foot view, you say, there's still a benefit here. 26% benefit based on the hazard ratio, a doubling of median disease-free survival. So clearly and I think this is consistent with what we know about the PD-L1 biomarker in this space, is the absence of PD-L1 does not mean you won't have a response, but if you have PD-L1, you're more likely to have a response. And I think how that translates clinically is we all have patients post-cystectomy that have had a very hard recovery, that are older, they're more frail, and that you look at them in the office and you say, wow, this person is not going to have a great time with any sort of systemic therapy at this point. For that group of patients, I think sending PD-L1 makes sense, because if they are a low PD-L1 expressor, it may influence your decision on their relative risk-benefit ratio for getting treatment. If they're a high PD-L1 expressor, again, they're more likely to get a benefit, and you may be more likely to potentially endure some of the side effects associated with this. So some of the subgroup analyses, and it's important to understand that the subgroup analyses were not powered to detect major to make any general conclusions about this. But NUTRFS is non-urothelial tract recurrence-free survival. So where did they recur? This group of patients, did they recur viscerally? Did they recur in their lymph nodes? You can see that as you extended the follow-up, both in the overall population and in the MIBC population, it favored the Opdivo group. So this is kind of a systemic recurrence, and this is kind of what you'd expect for an active systemic agent. And then PFS2, PFS2 is becoming a very important surrogate in a lot of cancer clinical trials. I think PFS2 is probably a closer indicator of overall survival than PFS1. PFS2 is basically the time from randomization to the time to progression on the second systemic therapy. So after they have failed this therapy, then they go on to the second one, and then it's the time to failure for that. So that's probably a better correlating metric of how they're going to do from an overall survival standpoint. Remember, the data in this subset is still not mature enough to give us overall survival data, but I think this is kind of moving in that direction as you see a hazard ratio in MIBC of 0.7 with the median follow-up of about 32 months for PFS2. So even if you get the Opdivo and you have progressed on that, you have a longer time to progress on your next anti-cancer agent. So kind of winding down here, we'll just talk briefly about quality of life metrics and also safety. In bladder cancer, and especially in the adjuvant space, quality of life is extremely important. These patients have been put through a lot with their non-muscle invasive bladder cancer treatments, and then a radical cystectomy, a urinary diversion. And then if you truly classify them as being eligible for adjuvant, the assumption is that they don't have active disease. So you really don't want to intervene on them with a therapy that's going to have a lot of issues with quality of life. And so this was an exploratory endpoint in Checkmate 274. Again, it wasn't powered to detect major differences or assess statistical significance, I think, but it's important to report this data. So there were two quality of life metrics that were used, a cancer-related quality of life and a health-related quality of life. And to really simplify things, we did not see any major difference between patients on placebo and nivolumab in this setting, which as a bladder cancer doctor is a reassuring thing, knowing that your patients who you are treating, and again, by the definition of adjuvant treatment, we're going to be over-treating some of these patients, right? We're going to be treating some patients who are not destined to recur. And so you really want to make sure that this is a well-tolerated treatment that doesn't really change people's quality of lives. And I think this supports that. So we'll close out by talking a little bit about safety. A lot of people are interested in, okay, well, we know it works. The data is clearly there. What do we have to worry about in terms of safety? So in Checkmate 274, which is the study we just discussed, 30% of patients had serious AEs. We'll talk a little bit about that. Low-grade adverse events are common. Quite a few patients who get this drug will have these. Rash, fatigue, diarrhea are quite common, and we'll talk about that. I think really importantly on the right, Opdivo was delayed in a third of patients. So the majority of patients were able to stay on the drug despite adverse events, and only about an 18% discontinuation rate due to adverse events. And I think really you have to use that data and compare it to what we see with adjuvant chemotherapy, where we're looking at 40 to 50% discontinuation rate due to side effects. So something that's clearly easier to tolerate and easier to access for these patients. So the plot here about safety, the Opdivo patients are in the blue and the placebo are on the right. So a couple of, high-level observations here is that these two curves are these two sides are fairly similar, and I think it goes to the nature of this population. These are urinary diversion patients, post-cystectomy patients. They are frail. They're recovering from a major operation. So things like urinary tract infection are going to be common in both groups. Things like musculoskeletal pain. The common things, rash, fatigue, which again is fairly similar in the placebo group. And what you'll also notice is the vast majority of these are low grade. The dark blues are the high grade, grades 3 and grades 4. Those are the side effects that make you delay or potentially withdraw patients from Opdivo. We don't see that very common. We see kind of this constellation of fairly common constitutional side effects. But then also you're going to see IRAEs, immune-mediated adverse events, which are basically the common side effect profile of all of these drugs, which is stimulating the immune system, and that can result in an itis, inflammatory cascade of any organ. So here you see things like cough, you see thyroid abnormalities. Those are things that again are more common. Again, important to note that rarely do these side effects take on a high-grade nature where you really have to treat the patient for the side effect. Oftentimes, these are mitigated by very local symptomatic treatments and maybe delaying the dose. So laboratory abnormalities, really important part of monitoring. I tell my staff and I tell patients the importance of, even if a patient looks well on these treatments, you have to monitor their labs, specifically getting a liver function profile, a complete metabolic count, and then also understanding their thyroid function. Thyroid function is something unique to this treatment pathway that needs to be understood. These patients, I would say in my experience, commonly develop thyroid abnormalities that do need to be evaluated. So I think a good summary here of what to expect with immune checkpoint inhibitors is that, this is disruption of immunologic self-tolerance. We're stimulating the immune system, and so any organ system can be involved. There is really no clear-cut prediction tool that says, okay, well, if this doesn't happen by this date, it's not going to happen, or this side effect happens at this time point, but not at this time point. These can be ongoing. These side effects can be significant after one dose. They can not be present until 20 doses. They can come on after the patient has stopped treatment. So it really highlights the importance of ongoing monitoring. If you're going to do it yourself, you have to build a team and a structure to be able to do this. Physicians, nurses, and your entire team who take care of these patients should understand and should get educated as to the side effects in order to make this a seamless process for everybody. And again, I would say the most common things that you see are rash, colitis, diarrhea, and thyroid abnormalities. Those are kind of the most common things you see. Pneumonitis, fulminant hepatitis, ocular issues, those things are very rare. And while they do occur, I can tell you that those are single-digit percentages. They need to be monitored for, but there are kind of a cascade of common side effects and uncommon side effects. So we talked a little bit about how timing is somewhat unpredictable here. There is maybe some method to the madness with predicting some of these things. Rash and dermatologic side effects are some of the most kind of early side effects that you see. as is thyroid. So when these patients come in for follow-up or monitoring, we look at their skin, we check their TSH. Down the road, the more serious side effects, things like pneumonitis, ocular side effects, adrenal issues, those tend to develop over longer periods of time with consistent exposure to the treatment. And then if you look at time to resolution of these adverse events, what you'll see is that, again, they don't just resolve right away. So the treatment, if you will, for patients with grade 2 or grade 3 toxicity or higher is stopping the immune agent, starting a steroid taper. That steroid taper is weight-based and usually is somewhere in the order of 4 to 8 weeks based on how they're doing. Most of the time, an oral steroid taper will solve the problem. If it doesn't, you may need to get more significant anti-immune agents on board. But again, that is pretty rare. But I think this provides a little bit of information in that, with a steroid taper, for example, patients who have diarrhea usually resolve their diarrhea within a fairly short period of time. Things like rash can be a little bit longer to completely resolve, and that's why sometimes you're going to need to use local therapies as in addition to systemic therapies. And then, the last thing I would say about all this is keep your specialists nearby. Immune-mediated treatments now are very common. And so a lot of subspecialists, GI, endocrine, dermatology, ophthalmology, these specialists see and know about these side effects and have a very good sense of how to treat these, whether to observe, whether to treat with topicals or local systemic. And so I would engage your local specialists. I have a host of them on speed dial for myself to help me if I'm somewhat in the middle of whether or not to treat or how to treat these patients. So again, that brings us back to the MDT. Patient education on this really has to be spread out, not just by the champion physician who's administering these, but to the support staff, engage other specialists, and really educate the patient in terms of what to expect, what could be something worth notifying you, what's something to expect. One of the things I tell the staff is don't let the sun set on a small immune-mediated adverse event. And really all that means is if a patient calls in and they say, I've developed a rash or I have a dry cough that I didn't have a few days ago, that patient needs to be monitored and they need to be called and they need to be followed up on. If those progress, small things can become big things if nothing is done or that patient is not brought in for evaluation. So treat and intervene quickly really is a kind of one of the biggest take homes. And I think, the central message here is develop a system to monitor these patients if you're treating them yourself. So, follow up in Checkmate 274. This is important because I think if you start giving these treatments, not only do you have to think about safety, but you have to think about the overall process of understanding their disease and understanding how things are going. So, laboratory testing, we talked about that, is necessary for safety. I will tell you, in the real world, this is the trial schematic. In the real world, we probably don't check labs as frequently as this. We probably check labs if the patients are symptomatic or every 3 months based on kind of my pathway. Imaging, fundamentally important in bladder cancer. We're getting cross-sectional imaging in patients every 3 months. And sometimes patients can't receive contrast, and you pivot to maybe an MRI or a PET scan or something like that. But imaging and laboratory assessment is really very important as you're trying to understand how these patients are doing. So, the last couple slides here, I think, are really just a big picture view of how the urologist now should be involved. Immunotherapy is coming earlier and earlier in bladder cancer. It's already here, we know, in non-muscle invasive disease, but now it's here in adjuvant bladder. we know it's there. There's an indication in adjuvant kidney as well. So urologists really need, who are treating these patients and doing a lot of surgery on these patients, really need to understand these drugs, what they do, how they're administered, what the side effects are, and they need to develop a team to be able to understand and counsel patients as to what's best for them. Like I said, I think one of the take-home messages here is, if you're not in an environment or a setting where you have a good multidisciplinary team, you have a tumor board that's reproducible, you have resources that you're giving patients, it's really important to do that because there's just too much out there now. There's too many things going on. There's too many drugs and trials for these patients that any one urologist can understand or manage by themselves. And again, I'm passionate about this. I think urologists, urologic oncologists should really be engaged in this. This is the future of our field, whether or not it's giving immunotherapy by itself or with combination treatments that we're already giving it before surgery, giving it after surgery. This is going to become the future of our specialty, and we really need to take an active role in understanding, how these treatments fit, how patients do, and how to manage these patients when they're on it. So, this is kind of a general schematic of the workflow and the MDT. But basically, we know the urologist usually sees bladder cancer patients up front. They do the TURBTs, but I think at that point, it's important to pivot to an MDT approach where medical oncologists, radiation oncologists are all involved in the decision on whether or not a patient should get a cystectomy, whether or not a patient should move towards trimodal therapy, how patients are going to be counseled throughout the process. And then, once that decision is made, the urologist can do the surgery. But then once again, at that next point where you get the pathologic information back, again, the MDT should be utilized to help understand how the patient should proceed from that point on, develop a surveillance strategy. Too often we find that patients can have great surgery, but they're not surveyed very well, or they don't have a plan for how they're going to be monitored post-surgery. So all of this stuff, I think, is fundamentally very important for these patients. So we'll close real quick on a case of mine. This was a 71-year-old male who had gross hematuria, and a sonogram in the ER showed a bladder mass. He showed up to me. We did a TURBT that was resected, a 5-centimeter lateral sessile tumor, and the path was muscle invasive bladder cancer. He had no distant disease, adenopathy, or hydronephrosis on a CT scan. But what we saw was that his creatinine clearance GFR was 41. So fits the criteria for cisplatin ineligible urothelial carcinoma. We discussed our options, and the patient opted for an upfront radical cystectomy. The pathology was invasive urothelial carcinoma, invasive into fat, with 2 out of 17 lymph nodes involved. So PT3A and 1 in a patient that was not eligible for chemotherapy pre-op. So post-operatively, the patient recovered fairly well. His creatinine clearance, unfortunately, did not improve that much. His GFR was 41. And so this is a great patient to discuss adjuvant immunotherapy. So we discussed the data. Again, there was a lot of node positive patients in Checkmate 274. That was, again, a big part of that study. So I thought this patient would be a great candidate. The patient underwent 12 months of adjuvant Nivo. And in my assessment, the patient tolerated this very well. He didn't have any treatment discontinuation. He did have an interruption due to a rash, but did not have a requirement to be hospitalized or get steroids. His CT scans were negative, and the patient is now 19 months post-completion of Nivo, and has no evidence of disease and is still being actively monitored. So this is a great outcome for someone who had node positive disease and couldn't get chemotherapy. And I think we're seeing this more and more in this group of patients who are able to get immunotherapy. I think it really has become a game changer. Many of you know the recent data of the immunotherapy and ADC combination that's now going to be kind of the new standard of care in metastatic disease. So clearly, immunotherapy is a very powerful agent in bladder cancer, and the cases like this are really nice to see. So, in summary, patients who have muscle-invasive urothelial carcinoma at high risk of recurrence, we know may progress to metastatic disease even if they get chemotherapy up front. So Checkmate 274 showed us that adjuvant nivolumab improved disease-free survival. And again, if you really want to get in the nuts and bolts of it, patients who had specifically muscle-invasive bladder cancer and who had PD-L1 expression that was high had the best benefit, but the whole group of patients did have a benefit as well. IO therapies are now kind of in our toolbox and have real benefit for patients who have high-risk disease, who maybe can't get chemotherapy or maybe aren't a great candidate for chemotherapy. And really, the last box is kind of the most important thing here. Urologists really play a crucial role here, and it's the awareness that we're trying to kind of develop of the multidisciplinary team, the newer options that we have for this disease, and the importance of the collaboration between oncologic specialists in trying to get the best outcome here for our patients. So we'll just close real quick. We've covered a little bit of this, but some of the important safety information. The immune-mediated adverse events, which we talked about, the inflammatory conditions may be severe or fatal, and it can really occur in any organ tissue system. The treatment of these is to permanently discontinue Opdivo in severe cases and to administer corticosteroids. And then there's a list here of some of the common or classic immune-mediated events: pneumonitis, colitis, hepatitis, endocrinopathies, again, treated fairly similarly, with the exception of endocrinopathies, which is usually treated with hormone replacement. And then, again, you start seeing some of your less common things like nephritis, severe dermatologic reactions, ocular toxicities. Those are all things that can happen. And again, I tell patients that anything under the sun in your body can be inflamed by this. There are certain things that happen more commonly, and those are the things that we talked about. Infusion-related reactions, just like patients who are getting any infusion, they can develop a flu-like illness after the infusion. High-grade or life-threatening infusion-related reactions are exceptionally rare. And then the last thing I'll say is in patients who are complicated, patients who have multiple medical issues, patients who are immune compromised, pregnant, lactating, multiple myeloma, these are patients that really should be dealt with in a multidisciplinary fashion, with medical oncologists and immunologists involved, as the response to these medications could be somewhat variable. So with that, I will close. Hopefully that wasn't too long and boring, but we have some time for questions if anyone has any questions. Feel free to type them in the chat. Okay. So the question is when someone needs IV steroids, are you giving yourself? So yes, so usually we do a oral course of steroids, and if patients are progressing on oral steroids, we kind of make the decision, how ill are they, or what's their need for further level of care. So if patients are not really acutely that ill, but say their diarrhea is not getting any better on oral steroids. We'll bring them in and we'll do IV steroids in the office. And we have a protocol for doing that. And we'll see how they do. A lot of those patients can be salvaged with IV steroids on an outpatient basis. There are a few patients who, even after that, they don't respond, and then they're going to need something more specific like mycophenolate or something a little bit more significant. In those cases, I send that to my medical oncologist or get an opinion from them. Now, if patients have had oral steroids at home and are acutely getting ill, they don't sound good, they don't feel good, that's when I usually bring them into the hospital and we'll consult appropriate specialists for IV therapies. But yes, the short answer is we are giving IV steroids for patients who are clinically stable and not responding to oral steroids. Okay, well, looks like we are at the end. So thanks everyone for joining us. And this will be part of the AUA series that will be able to be accessed after this. Oh, you may have. Okay. All right. This will be able to be accessed online. I appreciate the AUA and BMS for sponsoring this event. And thanks again.